UnitedHealthcare of Wisconsin, Tom Lutzow, Principal for Health Management Associates, Dave Ostendorf, Chief Actuary for Centivo, and Sean Kirkby, Assistant Editor of Wisconsin Health News, who will be moderating today's event. Before we get started, I want to make sure we thank our generous sponsors of the Wisconsin Health News virtual series. These important discussions would not be possible without their support. So a huge thank you to Advocate Aurora Health, AARP Wisconsin, Anthem Blue Cross and Blue Shield of Wisconsin, Gundersen Health System, Husch Blackwell, and WPS Health Insurance. Wisconsin Health News is an online, nonpartisan news service. In addition to hosting events like these, we also publish a daily email newsletter. If you are not yet a subscriber, I encourage you to sign up for a free trial, which you can do on our website at wisconsinhealthnews.com. And I want to give an extra thanks today to Gundersen Health System, today's featured sponsor. We are very grateful for all of their generous and continued support. Here to say a few words is Dr. Scott Rathgaber, CEO of Gundersen Health System.
Thank you, Tim. On behalf of the more than 9,000 people at Gundersen Health System who care for patients, families, and communities, I'd like to welcome you today to Wisconsin Health News virtual event on the future of value-based care. As a local and regional leader for healthcare quality, Gundersen has aligned practice and measurement of conditions and outcomes as core standards of care across our system. These standards were recently recognized by the Wisconsin Collaborative for Healthcare Quality. Gundersen was #1 in WCHQ rankings for cervical cancer screening, #2 for diabetes optimal control, and #3 among organizations our size for colon cancer screening. And I'm proud to report that more than 6,000 Gundersen patients with diabetes are meeting the standard for diabetes optimal control. This is great news. It helps patients with diabetes avoid poor outcomes such as kidney disease, blindness, amputation, heart disease, and stroke. And yet, efforts like these often fall short of those in counties with similar economies. Today's conversation on the future of value-based care zooms in on the necessary intersection of clinical quality efforts and the need to focus on and invest in the health of our population. Continuing and strengthening patient-centered, community-minded care is a primary reason Gundersen and Bellin Health are planning to merge. As we near the closing of our merger of equals, our collective focus is on investing dollars to improve health outcomes for everyone in our care. I look forward to today's discussion and to our work together to help our communities and our region thrive. Thank you, and thank you, Wisconsin Health News, for facilitating this event. Tim, I turn it back to you and to the panel.
Great. Thank you so much, Dr. Rathgaber, and thanks again to Gundersen for all of your support. With that, I'm going to hand it over to Sean, who's going to moderate today's event.
Thanks, Tim. Wisconsin payers, providers, and employers have recently launched efforts that aim to achieve high quality, affordable healthcare with an emphasis on primary care, population health, big data, and close collaboration. We've gathered some experts here who are involved in this work to talk about it. And I'd like to start with Dave. The Business Healthcare Group and Centivo are working together to steer patients towards high-value providers. Can you talk about what healthcare trends are facing employers and how are you two approaching these issues?
Sure, Sean. The real focus that the employers at the Business Healthcare Group, along with Centivo, have taken is to look at the way to change healthcare consumption and healthcare provision in this marketplace with a heavy emphasis on advanced practice primary care and having strong primary care relationship, which is really the foundation of all the work that's being done. We have found that there is a huge opportunity to both improve the primary care that is provided, but more importantly, to have people have a well-guided experience through the healthcare system. And what we've tried to do from both the employer side and in our work with the health systems is to create alignment across all of the key points. That includes having strong relationships between patient and providers, having the issues that allow providers to be accountable for the overall care of the patients, having employers step up and have plan designs and program features that really reinforce those relationships, and then have contracting strategies that reward those who do their best job in providing the best outcomes at the most cost-efficient price.
And when it comes to primary care, why the focus on that field? Is that going to be enough to have an impact on, some of the cost trends that employers are seeing? Are there other areas that are going to be the focus of this relationship?
Yeah, we found there's a great opportunity around the primary care side of things. When you look at what we have found in other marketplaces across the country, we've been able to reduce costs overall, the total spend by around 15%. But we have found that in doing so, we often end up with primary care that's significantly higher than it was before. And what we really found is that for every additional dollars we spend on primary care, we're saving about $3 in downstream care. That's the economics that really work. It's also the patient experience that really works. And so the combination of the two has really come together in a way that's very beneficial.
This relationship has been ongoing now for like a year or two, and you just mentioned the primary care dollars. Can you just elaborate a little bit more? What impact have you seen so far through steering patients to these higher value providers?
Yeah, one of the things that the BHG employers did in conjunction with the health systems is to really look at some very in-depth data around the performance of primary care providers, and the value proposition to anybody joining one of the high performance plans has been that you will have a strong relationship with a high performing primary care provider. What that said is that there are certain providers who haven't yet met that standard and aren't available to be the ones coordinating care. That opportunity has really found a sweet spot in terms of saving both financial resources and in terms of improving where care is provided. We've also taken the data and used it to refer to higher performing specialists in a number of specialty procedure areas. And so that piece of it, in addition to what we're seeing on the primary care side, has really served the membership well. We're seeing substantial savings, double-digit savings over where employers have been, which is obviously very beneficial, but it's really getting the right care at the right place that's driven that, as opposed to simply spending all our time talking about how do we get better unit prices, which has been really where the marketplace has been historically.
Got it. So Dr. Brady, what are insurers seeing? I mean, what pressures are kind of prompting you all to move towards value-based care?
I think we're all well aware that healthcare spending just continues to rise in the US, right? We approached in 2020, 20% of the nation's GDP was spent on healthcare. It's estimated that over $1 trillion of that is on wasteful spending that really doesn't improve the quality of the care or the experience that was delivered. The good thing is in the state of Wisconsin in particular, but even across the nation, we have a high rate of people who have insurance. Over 90% of our citizens are covered under a plan, the majority under a private health insurance plan. So I think it's really us as an industry, as a payer, but really a health system industry across the US to do something different, to change the modalities in which we reimburse our providers, but also to really rethink how we engage and interact with each other. Our members, our patients, our communities, our neighbors deserve that we do something different. So that's really our focus, is making transformational change away from, as Dave put it, contracting activities, fee for service, paying for each service that's delivered, and really looking at how we can reimburse based on the value that's delivered to the patients that come to seek care.
And when it comes to that, what types of value-based arrangements have you all been pursuing, and what percentage or how much of your business is in these areas?
Yeah, so here at United, we kind of break it down into 4 main categories. And for the most part, there's kind of a spectrum on the maturity of a provider group in doing population health. So we look at performance-based contracts, which are kind of the beginning, the entrance phase for value-based contracting. Similarly would be bundled or very service or specialty specific arrangements. And then things get more mature when you're talking about being accountable for the total cost of care. So our accountable care organizations are really at that high level of maturity, would be capitation. And it really varies across the US at what you see. On the West Coast with the Kaisers out there, there's a lot of capitation, but it's very narrow networks, where here in the Midwest, we see many more accountable care organizations or ACOs, and we tend to have broader networks. Here in Wisconsin, we're really fortunate. About 45% of UnitedHealthcare spend is linked to value-based contracting in the commercial space.
And when it comes to that, what impacts have you seen from doing that? I mean, what have been kind of have you seen financial savings? Have you seen improved quality of care through these arrangements so far?
Yeah, again, we have some really fantastic accountable care organizations here in Wisconsin. We do use performance-based contracting as well, but I'm going to speak to the accountable care organizations because they are absolutely wonderful. And we have seen that we have improved utilization. So again, people seeking care at the right time, at the right location. We have seen better chronic disease management, which leads to less admissions to the hospital and ER visits. We have seen a lower total cost of care, not just through managing utilization better, but also looking at pharmacy and, again, better management of chronic diseases and preventative health. So our ACOs close more gaps or make sure that more of our members get their appropriate cancer screenings and chronic disease screenings, and our kiddos get their well child exams and immunizations. So it really drives a higher quality of care.
And when it comes to ACOs, I know that you all are about to launch a Nexus ACO in Wisconsin, which includes some close collaboration between major competing health systems in the area. Can you talk a little bit about this approach? Why are you taking it, and what do you hope it achieves?
You know, I think we've been really fortunate. Again, we have these strong ACO relationships, which means that as a payer and our providers in these ACO agreements, we partner side by side. We work together very closely. We share data. We make sure our members, our patients, our communities are best cared for. And really what this Nexus ACO products is it takes these ACOs that we have, but it also marries it to some accountability on the employer and the member side, and making it easy for employers and members to choose their PCPs, to insist that employees have a PCP and seek care at the PCP, and aligns that with the goals of our ACO. So we're really fortunate that we have 4 engaged provider groups: Aurora, Freighter, Medical College of Wisconsin, and Children's Hospital of Wisconsin, that are all willing to come together collaboratively to work towards these shared goals to really improve the health of our communities while controlling costs.
Thanks. So Jennifer, Advocare Aurora Health is part of this Nexus ACO. Can you just talk a little bit about, how does this compare to what other sort of arrangements you have? And is there anything that's different or unique about it compared to what else you're doing in this space?
Well, I think what I'd like to start with, if it's all right, Sean, is kind of a higher level focus on how we think about value-based care with Advocate Aurora. It's really embedded in our DNA and everything that we do, everything from the patient experience, as well as the high quality, high value care that our providers together across the integrated delivery system, provide every day. And it's our obligation to keep our communities healthy and serve our communities well. So it's really embedded in our DNA. So when we sit down to have a conversation with Nicole and her team or another payer partner, it's very it's like riding a bike for us, right? I mean, it's the work that we do every day. We have a lot of experience in some of the more traditional value-based or ACO channels, including the Medicare Shared Savings Program, where across 3 ACOs we've saved substantial sums of money for Medicare. But it's also more about providing that high quality care to our patients and of course the payers' members. And I think one of the things that we think about every time we enter a conversation with folks at United or another payer partner is really envisioning where we want to go together. What does that agreement need to look like? And as Nicole talked about, there's different levels of risk. I think Nicole laid it out nicely, very closely follows what HCP Land does as they're looking at as the continuum from fee for service all the way, to the deepest risk types of contracts that you can have with capitated agreements, and we have everything along that continuum. But I think the most important thing is not only the data, and I think we'll get into that later in our conversation, but also transparency in that approach. And I found in some of my previous experiences measuring providers on a national basis that if you take the approach that you're moving and bringing everyone along for the good of the community, but also for the physicians as well, telling people what their targets are, how you expect to get there, and what the ultimate goals are, and then sharing that data and bringing everybody along together in a transparent way really does help inform not only how we think about our work within the ACO, but also how we approach our payer partners and working closely with them to achieve that.
When it comes to these types of arrangements, how much of your business is within them? And about how much is in them?
Well, we're looking across 2 states. There's a substantial amount of our commercial spend that falls under value-based agreements, but we also have value-based agreements in other lines of business beyond commercial, Medicare Advantage and Medicaid as well. And I think we have an obligation to have those types of agreements across all types of the population. And I think we've all heard stories of our providers, whether affiliated or employed. They don't want to treat a patient differently based on what their payment source is. They just want to do the right thing for the patient. So when we're working behind the scenes with our payers, we're really thinking about what are the quality measures and metrics, and not necessarily what the payment mechanism is, but what is it that provider needs to do to provide, the highest quality patient experience, high quality care, high value care, that helps, get us overall where we need to go. Certainly in the Medicare shared savings space, there's millions of dollars that go through those agreements. And we anticipate, continuing to work in that space going forward.
What types of pressures are providers facing when it comes to these kind of arrangements? Are you all looking to move more into them, or are there some areas of your business that you want to see remain in fee-for-service?
Well, I think the best way to think about this is what's the right thing to do for the community? What's the right thing to do for our patients? And what's that patient's experience with us and how they interact? And I think a lot about, especially in the commercial space, I think a lot about how a member navigates their benefits, because oftentimes in a value-based arrangement, you're going to see a narrow network. You heard Dr. Brady talk about that arrangement with Nexus. Not everybody is participating. Not everybody provider is in that. So if I'm sitting there as a member and I'm trying to navigate my benefits, obviously that I want to get to the right place at the right time. But I think we have an obligation as a healthcare system to work closely with our payer partners to make that, seamless and easy. Because it's, the point of care might be an emergency. You're certainly not going to shop for a heart catheterization if you have an, emergent situation with a family member. You want to be able to pick up your phone and, for Advocate Aurora, we have the Live Well app and, help somebody navigate what is it that's going to keep me inside my network, so that they have, the best possible experience. So I really think about it through that lens and how we look to grow the business with our payer partners in a way that works best for those members, especially in the commercial space. Medicare Advantage and Medicaid, are a little bit different just because of the nature of the funding streams and how those programs work. But I think ultimately, we're looking to move the needle forward wherever we can. But again, truly focused on that patient experience.
Thanks, Jennifer. Tom, we just heard about a series of value-based payment models. Can you put these into a little bit of context? Are these kind of the main ones that are out here, or are there other approaches that we kind of haven't talked about yet that I think are important to highlight?
Yeah, certainly you've covered a number of them: global payments and capitations and performance reimbursement based on performance measures and so on. I think some plans are doing some unique things with maybe the ancillary providers that are a little unique. And that's using a withhold earn back. That's something the state uses on the Medicaid side, but it's also something that some plans are using with ancillary providers. It's important to, when working with any provider, but certainly the ancillary providers will tend to be a little bit smaller in size, to make sure that the measures are well chosen, that they're within reach of the provider to achieve. And if you have an agreement on what those might be within their wheelhouse, you can have an effective plan, that pays based on quality performance. So there are some different approaches, selections of measures with any provider. It needs to be well considered. You can't have a one-off performance chase that isn't within the standard management practice of the organization. So that's a fundamental piece of making these performance-based contracts work. So in any conversation with a provider, you need to understand, what is that provider working on that's within their standard practice of management, and working within that behavior and building on it instead of introducing something totally foreign is key to success here.
Got it. So when it comes to the impact that this has had on cost, can you kind of talk a little bit about, what we're seeing kind of globally? How these models kind of moved the needle? We've had them for a few years now. Have we seen their promise come through?
Yeah, I think we're still in the process of winnowing through what works and what doesn't work. I think there's some disappointment on the volume of savings achieved. I think there's still providers that maybe a little risk averse, that maybe agreed to an upside incentive, but an upside and downside incentive is a little bit more elusive, and they aren't as comfortable with that. And there's where transparency and true partnership between a payer and provider are critically important. If there's distrust on either side, the relationship won't work. And so there again, I think we're getting more and more sophisticated. A lot of the ACOs and especially provider-owned payer plans have great analytics, are able to get information, quality information, risk assessment information in front of the PCP at the point of care. And you're going to see more and more confidence on the providers that they can manage this risk environment. And that's the question. Do they feel comfortable managing an upside and downside risk environment? And if they are, and the tools are becoming more and more plentiful to do that, you're going to see this get more traction. Value-based purchasing is going to get more traction. It's not going to go away.
So Tom, just to kind of follow up on that, what do you sort of see as the limitations of these kind of arrangements? Like you mentioned at the beginning that they don't work, that there isn't evidence that it's working in all cases. Is it possible to put all types of care into these types of contracts? Or how does, for example, behavioral or mental health fit into this equation?
Yes, certainly as you get into some of these areas, for instance, the burden that both the payer and the provider system now has, the emerging burden of dealing with social determinants. You're talking about something that's pretty elusive, and maybe not within scope of their ability to do anything about it. But if you tie reimbursement to that, I think there's some concern that you're moving outside of healthcare and burdening the healthcare system with something that it can't control, whether you're a payer or a provider. So I think we need to be careful what we're burdening the healthcare system on both the provider and the payer side with, and make sure it's within scope to address. The thing about the payer and provider relationships, there's a key player in all of this, and it's the patient. And if that patient isn't committed to self-care, the provider and payer is severely limited in what can be delivered on the outcome side. So patient engagement, patient motivation, they're a key player in all this. They're a partner in the success of all of this performance-based contracting.
So when it comes to Wisconsin, Tom, how does it kind of compare to the rest of the nation when it comes to value-based care? I mean, are we seeing more things done here than elsewhere, or is it in line with what we're seeing across the country?
Compared to other states, I think Wisconsin is maybe a late adopter. It's being, the take up here is definitely, you can see it, but they're not at the cutting edge in terms of adoption.
Got it. So Dr. Brady, when it comes to UnitedHealthcare, I mean, where does kind of Wisconsin stack up compared to other markets?
If we look at just our commercial membership, I had mentioned earlier that about 45% of our spend is linked to some sort of value-based contract. Compared to regionally, so central United States, they're at about 38%. Nationally, we're at about 40%. So we're doing pretty well. To Tom's point, though, if you then dig into the type of model, whether it's a model that's more on the immature side of the spectrum versus the mature side, we're kind of in the middle. We're kind of developing into those great ACO models, but most of them still are upside risk, and we haven't advanced the downside risk. We don't have capitation yet. So I think we're doing very respectfully, but again, we do obviously have opportunities to improve.
Dave, do you want to weigh in on this too? How does kind of Wisconsin stack up to what we're seeing across the country?
Yeah, I generally agree with what Tom and Nicole said as far as where Wisconsin is. I think one of the things that is always an important question to ask is where you're really trying to get to, because I think a lot of people jump immediately to global cap is the best way to go, and that's where we should all be. And it's often the case that may not be the right answer. And especially in those situations where we, as we do in Wisconsin, have most employers providing employees with options, one of which is often a performance-based option that has a lot of ability for value-based, and another which is a more traditional open-ended PPO option. We end up with a lot of entities trying to cherry pick their lives and get the right risk profile in their plan that is on a global cap basis. That really doesn't help any of us, because all you're really doing is reversing the financing. And so I'm going to bring my actuarial perspective on it. When I get the wrong people into the global cap arrangement, I paid more for them than I need to, and I'm still paying more than I need to for those who are in the more traditional fee-for-service world. So I've got to be really thoughtful about where my desired end state is. And so a mindset that says, let's just race to global cap as our ultimate solution may not be the right one. And I think we have to be more thoughtful about saying our reimbursement models really need to reward things that are creating positive change, not just refinancing a system that isn't working well for everybody. And that, I think, is critical. And when you evaluate various models, that has to be your mindset. Otherwise, we're going to be sub-optimizing all the way through.
Thanks, Dave. Jennifer, do you want to weigh in on this? I mean, where does kind of Wisconsin stack up here?
Healthcare is very local, right? So, I mean, it's what you get in your neighborhood, and what works in North Carolina or California isn't necessarily going to work in Wisconsin. We have a lot of rural hospitals and rural providers that we have to be very mindful of to ensure that they're there for the long haul to provide care in the reaches of our state where they're most needed. So I think when we're talking about some of these models, and what may come in from the coasts, and Dave's comments about global cap, we have experience with global cap as well. One size fits all isn't going to work for every provider. There's a sophistication level there that when you start moving into the insurance space, it's a whole different world. And I think oftentimes it's easy to pick up media and see where some of the money's being made or where margins are being made on the insurance side, and think, well, maybe if I do a couple of these arrangements, then I can capture, some of those dollars from a margin capture perspective. And to some extent you can. It just depends on the model, but I think there's the bottom line is you have to be very careful on the models that are presented, by the payers have to be transparent. You have to understand the underpinning of them. You have to understand attribution. As Dave said, who are the patients in your pool? How is the risk being managed? What's the division of financial responsibility? Are you responsible for everything, including transplants and NICU babies? Or are you taking partial cap with Part B versus Part A? I mean, the list of questions that you need to ask yourself as you move into these types of models is, almost never ending. We spend a lot of time with our actuaries. We've become very close to them. Dave, maybe that would warm your heart. But we spend a lot of time with them understanding, what that risk profile is and how important that is to being able to manage a population. It's certainly not for the faint of heart.
So Jennifer, just to stay with you for a sec, we've gone through the pandemic for the last few years. How has that kind of impacted these efforts? I mean, has it slowed them down or is it propelling them forward?
It's interesting because I think as we reflect back on the beginning parts of of COVID, and a multi-year into this, who would have ever thought? But in those initial months when, everything was closed down, certainly providers that were in capitation agreements and had, a guaranteed revenue stream, that was the right place to be. So I think that brought a lot of attention to these models and working, with some of the payer partners to say, hey, maybe there's something here that helps kind of, maybe put some guardrails around the system when we're facing something big like COVID. And you move into, 21, where care came roaring back. Everything that had been deferred in 2020, hit in 2021. At the same time, we were experiencing successive new waves of COVID. Now, on the upside, we were prepared for those COVID patients at that point as a delivery system. I think more people were vaccinated. We knew how to handle the patients. We also knew as a healthcare delivery system how to, quickly deploy resources, whether it be nursing or respirators or whatever we needed to do into different.
I think Jennifer may have froze on us. So if she returns, oh no. Okay. Sorry, Jennifer. I think you kind of went out there for a second, and I may have also had some internet issues. So you were talking a little bit.
My finger up my nose.
Yeah. I think you're with us, or maybe Dr. Brady, you want to jump in for a sec?
Yeah, I think I will. I'm going to kind of take off where Jennifer maybe left off. I think initially when COVID first hit, I think that clearly put a damper on working towards any advancements or changes in contracting with our provider groups. I mean, clearly we had to shift efforts even as a payer to contracting to say, hey, how can we support our providers? Can we relieve managed care activities? Can we do advanced payments? Like, how can we support them? But I gotta say, here in Wisconsin, our providers reacted really, really well. They managed the pandemic well. They treated our family members, our neighbors, our patients, our members fantastically. And they were really quickly able to shift to develop new treatments, telehealth, innovative ways to close gaps in care. I think our experience with our ACOs was fantastic, that even though there was initially a dip in like cancer screening and preventative medicine, by the end of the 2020 calendar year, they had almost completely caught up and had similar results to 2019. Our Wisconsin-based providers have always been high quality, and they didn't let the pandemic beat them. I think what's really great is all the new innovations that came out that we're going to be able to continue long-term to really improve quality while we control costs. So kudos to our Wisconsin providers who just navigated the pandemic fantastically and really have recovered well. I mean, that's why we were able to launch this new Nexus product for 1/1/23, is because despite the fact that we weren't out of the pandemic yet in 2021, they were able to come to the table and start discussing again, what can we do to make this work together?
And Sean, I want to pick up on something Nicole said, because it's really important. You know, there's always been the perception that change in healthcare is really slow and really hard, and it is hard. But the pandemic showed us that it doesn't always have to be slow. You know, the adoption of incredibly high rates of telehealth, for example, you know, ideas that had been, you know, plans that have been put on the table with the, you know, here's the 5-year implementation plan became a 3-week implementation plan. And, you know, groups like Jennifer and her team and others, you know, across the Wisconsin landscape did things that were so effective so quickly. And, you know, we should have a higher expectation that we can make those kind of positive changes quickly, because we know we can actually do it. And that was, you know, if there's ever a silver lining to something as awful as a pandemic, it was things like that.
Got it. Tom, do you have any thoughts on this?
Well, the certainly providers who were capitated during the pandemic did very well. I mean, capitation continued to flow even though utilization wasn't where it had been. Providers that were in the fee-for-service environment suffered quite a bit, because utilization went down, and so did reimbursement go down. I think some plans, as part of the recovery, did increase their reimbursements to providers for certain services. Among them, the big one was in Medicare environment, was the annual wellness visit, to try and get members back in to see the PCP, whether telephonically or in person. I think some of them actually paid a premium if it was in person, understanding the costs were increased to make sure that, you know, that visit was managed correctly, protected correctly. And there was a huge growth in in-home service delivery by nurse practitioners and others, and incentives built around that as well. So I do think providers and payers sort of extended themselves significantly in response to COVID to try and regain that relationship and restore face-to-face as much as possible.
Thanks, Tom. Jennifer, I know you cut out a little bit there, but is there anything else you want to add or touch on that I can't remember precisely where? I think I was having a few internet problems of my own for a second there. So anything you want to touch on for this question?
We're going to have a blip in our data for the rest of our careers. I guess that's kind of the point I was trying to make, right? I mean, you used to be able to pick up 12 to 18 months worth of data and be able to reasonably predict where you thought costs were going to go and how you'd manage that population. Not so. And I think just the variation that we've seen in 20 to 21 to 22, and then what we're anticipating in 23, which, you know, goodness knows where we'll head, especially related to the inflationary pressures. It's anybody's guess, and you know, we have to just be very transparent with each other. You know, conversations that we would have with you know, Dr. Brady's team or other payer partners, and just be willing to put as much as we can on the table and explain, you know, what we're seeing, so we can solve things together. That's going to be the only way we move these things forward.
So Jennifer, just to stick with you for a second, you mentioned some of the inflationary pressures that health systems are facing. I mean, what types of barriers are there now towards moving towards more value-based contracting? What are kind of some like those major hurdles?
So I don't see the inflationary pressure in and of itself a hurdle into value-based care. I think the hurdles that I see, and this is more of a macro level, so this isn't necessarily our exact experience, but is really the transparency of the models. And are things done in a black box behind the scenes? Are we able to see the attribution? Are we able to see the quality performance so that we can then share that with our aligned and employed physicians and really drive what we all want to accomplish? I think the biggest barrier, and you think back to the 90s with some of the HMO models, and then when everything started coming around again in the early 2000s, we all said, oh gosh, this time we're going to solve it because we're going to have data. Well, okay, yes, we're going to have data, but we also have to be transparent with each other about how we're measuring performance and what we're trying to accomplish. So I think it's that transparency that is going to be key going forward.
What do you think, Dave? Is that what you see as one of the biggest hurdles?
Well, I completely agree with what Jennifer just said. I think one of the biggest opportunities is to find ways to use data better with full understanding on all parties as to what that data is and how it's going to be applied. And I think, we have always underutilized data in the healthcare space. And part of that is just we've had competing factions that have wanted to use the data differently. If we didn't like the outcomes, we always picked on the data, and we picked on the data processes, we picked on the algorithms and said, you clearly didn't measure me right because you didn't show I was the best. So obviously it's not a problem with what we're doing, it's a problem with your data. And I think we're sort of getting past that, where we're saying, that the data tools are out there, the data sets are out there. Wisconsin, between having the Wisconsin Health Information Organization and having WCHQ and other state repositories for data give us a starting point, but using that in a way that all parties understand and not spending all our time trying to do everything under a proprietary blanket where we say, well, we can't really tell you that because it's our own stuff and we're never going to let you know what it is. I think has always been a challenging approach. I think it's one of the things that employers in the state have really been frustrated by is that they've often had trouble getting access to their own data. And they don't believe that health plans should own the data or others should own the data. They believe that when they're paying the bills, they should own the data, all the way up to the point of what the contracts say. And if value-based programs are really going to work, everybody has to be moving in the same direction. It needs to be on a collaborative basis, and all parties need to understand what really is the deal and how it's being measured.
Dr. Brady, what do you think about the challenges moving forward for value-based care?
I'm going to just continue to go on the data. I mean, quite frankly, it is key to being successful in these value-based reimbursements, transparent, open data sharing, but a lot of this data contains either proprietary information or personal health information, and there are strict regulations on what you can or how you can share it, which can really be a burden when you're trying to navigate these relationships. The other thing I would say is the U.S. healthcare system is very disjointed and complicated. And just because a member attributes to Jennifer's wonderful ACO doesn't mean they get all their care at Aurora. So they could have care elsewhere. They could be going to on-site clinics with limited availability of insight to that data. And so everything we can do to bring data together so that our providers really can see a holistic picture of that member and what their needs are, they're going to just be better at helping that member make good choices and better managing them. So data is really, really key. The other thing I would say that can be a barrier and that really providers have to work through, and I think Jennifer can probably comment on this even more than me, is it's a big infrastructure shift when you come to managing individual patients who walk through your doors, individual visits and procedures, to managing populations, some of which of those people might not even want to come through your doors. And you have to do proactive outreach, education, case management. These are things that if you look 20 years ago, our provider groups weren't great at. We didn't have robust case management resources. And now those sort of things are really key to being successful in these arrangements, but understanding that that takes resources. So how can you best reimburse providers so that they can set up and build this infrastructure on their way to that sophistication to really take on more risk.
Jennifer, do you want to comment on that? I mean, what are the infrastructure challenges that are involved for providers?
Well, just building on our experience in Illinois with our ACO, we get a lot of services delegated to us, and I think that's really important to being able to manage the population, whether that utilization management or even claims payment. I think one of the reasons why we, as a healthcare delivery system or an ACO, might want claims something that we would be paying, which may seem strange, but that's a great way for us to understand all of those data points without having to have it flow back through another mechanism back through the payer. You can get it, obviously at the time you're paying the claims. So, utilization management as well as any sorts of prior authorization procedure or prior authorization procedures are things that you might want to consider delegating. But as you said, in order to do those things and kind of stand in the shoes of the health plan, there's infrastructure costs there that come about from that. And that's also not for the faint of heart. And when you're building those things, whether it be, claim shops or call centers or teams, it's not necessarily scalable based on the number of members that you have. I mean, you've got to be able to get to, a certain level of service in order to be able to take those services delegated. And there's significant costs associated with that. So when we're evaluating the performance of a risk-based contract, you have to look at your infrastructure costs and what it is that you've assumed from the payer partner. And there are some parts of the business too that you don't necessarily want to delegate. It's going to depend. The payer might not want to delegate. It's going to be dependent upon on the population. Commercial is going to be different from Medicare Advantage. It could be different from Medicaid and what could be delegated. And you have to be able to perform those services and do it well. And it's not inexpensive.
Tom, what are your thoughts on this? I mean, are data and kind of some of this infrastructure challenges kind of the main hurdles here?
Yeah. The whole idea of, where you want to get to here is certainly a provider plan partnership. And it's an important word that, but in many cases is still an ideal. Sometimes a plan like Kaiser is held up where the provider owns the plan. And so you have the same governance structure essentially operating both sides, the payer side and the provider side. And so certain efficiencies can be presumed there in terms of prior authorizations, reconsiderations, some of the barriers and, the administrative complexities that sometimes are imposed on providers by plans can be dispensed with because it's under the same governance structure. So, that's where irritation and chafing can occur between a plan and a provider. That sometimes when the plan is owned by the provider, that doesn't occur. So, yeah, it certainly data sharing, but administrative functions also have to be aligned correctly for there to be satisfaction in the relationship. And historically, there's been a certain amount of chafing there that needs to go away, and it can go away with an understanding that the plan is here to support the provider, and the provider also needs to adopt the plan's performance measures too. It has performances to achieve on the HCC side and the 5-star side, and if the plan is convinced that the provider shares their burden and is working with them, you may have the foundation for a true partnership. And so it remains an elusive goal in many cases, but where you have common ownership, the provider owns the plan, you probably have a model where that complexity has a tendency to go away.
So Tom, looking forward, I mean, what do you sort of see as the future of these arrangements? Do you expect to see more and more emphasis placed on value? Any kind of pushback from folks over it?
No, I think on the provider side, there is even an appetite to be paid based on value as opposed to fee for service. I think there's a commitment to that. It's built into the system at this point. So I don't think providers want to go back to the fee for service structure necessarily. They want to be held accountable for outcomes and quality and consumer satisfaction and a host of other things. If they have an ACO structure, they made a commitment to that way of being reimbursed. So physicians under the alternative payment model and MIPS and all of the other structures that are being imposed on them by CMS are being driven to value-based relationships. They're becoming more and more comfortable with them. Now, moving then to upside and downside risk, that's a different matter. And that's where transparency and true partnership, both sides have to trust each other, payer and the provider have to trust each other that games aren't being played here. And so to get to that trust is part of the challenge. But I think everybody wants to get there. With interoperability, there's even a greater chance of connecting information systems, both in terms of reimbursement, what are plans collecting by way of premium and what are they paying by way of premium, and what are providers charging by way of costs, all of that. We're going to get to a level of transparency where a true partnership can occur.
Jennifer, do you want to weigh in here? What do you sort of see as the future of these arrangements?
Well, I think we'll see them continue to proliferate, but I think the challenge for all of us, and Tom touched on it a little bit earlier, is some of the health inequities and disparities that were so highlighted during the initial stages of the pandemic and have stayed with us. What opportunities do we have under those models to really embrace our communities in new and different ways, remove inequities and disparities, and do that in the context of some of those agreements, make sure that we're, addressing, truly the needs of our populations. I think the quality measurement space, the underpinning of, value-based care can continue to evolve. And that's another area where I think we can collectively work to do a lot of good for our communities. Think about maternal health, for example. What opportunities do we have to tackle some of those, substantial disparities for Black and Brown women in our communities who aren't receiving the care that they should and that they're entitled to. So we look forward to working with our payer partners to solve some of those really big questions facing our communities and the people that we serve. I think that's some of the most important work ahead of us, regardless of the payment model.
Got it. Dave, do you want to weigh in? What do you sort of see as the future of these kinds of value-based contracting arrangements?
Yeah, I think we have to get better at addressing some of the pain points that exist in the value-based contracts today. As you think about value-based reimbursement, all of that is predicated at the end of the day on provider accountability. And if we're going to ask providers to be accountable, we've got to equip them with the elements that allow them to be accountable and give them the control necessary. So, simple things like retroactive attribution models that say, I'm going to look at the end of the year and say, well, this was your patient, and why didn't you do better with them? Because the patient stopped in and saw you once during the year. That isn't a particularly effective model. Let's think about ways to move retroactive attribution into proactive assignment. Can we structure programs that do that? That's one of the big things that the BHG employers did, is they said we have to have a proactive assignment beginning of the year of people choosing a PCP and letting the PCP know who's on their panel, who they're accountable for. Simple things like that address one of the most critical pain points. We've got to think about the unintended consequences of certain things we're doing. When we put in high deductible plans and it was too expensive for people just to go to the doctor, not shockingly, we didn't get as much routine care as we should. We didn't get as much compliance with medications as we should. There are asks that the provider community can make of the employer and plan sponsor community that really should be out there. And if there are things that need to happen relative to program design, relative to fundamental elements that touch the patient, we should be having those conversations. The ask should go both ways, not simply towards the provider group. Once that control is in the hands of the provider community, they should be held accountable. They are looking at a whole patient management experience, not just a limited amount of interactions. And therefore, there should be a value-based approach that goes along with that. I think we can get there. I think we have to address the pain points. I think it has to be done in a way that both sides are listening to each other, that they're sharing data with each other, that it is a collaborative process. This isn't an imposed system. It has to be done in collaboration. I think we're getting there. I think we'll keep getting there. We'll keep moving better. I do think the world of, most of our reimbursements being in the fee-for-service world is done. But, the faster we can move towards truly acceptable, accountable kinds of value-based reimbursements, the better off we'll all be.
Thanks. Dr. Brady, what do you sort of see as the future here?
Yeah, I do think that the value-based contracting is going to continue to grow. It's going to continue to evolve. Everybody's kind of pointed out how there continues to be pain points, and we need to recognize that this still isn't the standard manner of reimbursement, and there is no standardized value-based contract. It is variable from payer to payer and product to product, and so trying to learn really what works best at a national level or more global level, and then how that applies to individual and local markets. So we're not losing focus on the fact that healthcare really is local and communities are different. So really learning as we move along, but having those collaborative and transparent relationships so that we can continue to talk and vet out these areas. Like Dave pointed out, attribution is an ongoing conversation. And you can see when you think of the future of value-based contracting and ACOs in particular, you could see the direction that payers and providers are going. We used to attribute members based on a claim coming in that said, hey, they saw somebody in your system. And now we're trying to get proactive. And through the BHCG model and through our Nexus ACO, we're saying these members need to pick a PCP up front so that our health systems know who they're supposed to be managing and outreaching to. So I think we're going to continue to see a lot of evolution on the way that we deploy these value-based contracts.
Got it. So we're almost out of time, and I want to thank our panelists for all participating. I want to thank our viewers for tuning in. In terms of future events, next Wednesday, we're doing an in-person newsmaker event in Madison with WPS Health Insurance CEO Mike Hammerlich. We'll be talking about the most pressing issues facing his company and the insurance industry at large in Wisconsin. So if you'd like to come to that, more welcome to. So thanks again for a great panel, and have a great day, everyone.